Welcome to this explainer. Today, we're diving into a complete, literally textbook-replacing masterclass where we unpack every single critical detail of neuromuscular blocking agents. Seriously, we're going to go point by point, ensuring you walk away with crystal clear concepts without ever needing to open a book. Let's explore the fascinating pharmacology behind these agents together, right now.
Here is our roadmap for today. 1. Rules for blockade. 2. Succinylcholine. 3. Rocuronium. 4. Intermediate agents. And finally, reversing the muscle blockade.
Section 1. Rules for neuromuscular blockade. The golden directives.
Okay, so the absolute most critical takeaway here is that these drugs do not affect consciousness. They literally do not cross the blood-brain barrier to provide any anesthesia whatsoever. So a paralyzed patient might be completely awake, feeling all the pain, but utterly unable to communicate it. Because of that, you absolutely must secure the airway with ventilation, and I cannot stress this enough, always provide simultaneous sedation.
Clinical classification is based strictly on onset and duration, which tells you exactly which agent you need to grab in an emergency. Succinylcholine sits all by itself in the ultra-short category, kicking in at just 1 minute and wearing off in about 5 to 10. Then, we step down to the short-acting rocuronium, which shares that super-fast 1 to 1.5 minute onset, but it sticks around for up to 35 minutes. And finally, our intermediate agents, vecuronium and cisatracurium. They take slightly longer to act, but give you sustained paralysis for a solid 40 to 60 minutes.
Moving right along to Section 2, the ultra-short agent, succinylcholine, the rapid depolarizer.
Succinylcholine has a totally unique mechanism of action compared to the rest of the pack. It's actually the only depolarizing ganglionic blocker we use. So unlike the others that just kind of passively sit on the receptor and block it, succinylcholine actively depolarizes the motor end plate. This causes these visible, uncoordinated muscle twitches, we call them fasciculations, right before flaccid paralysis sets in. And then it's rapidly cleared out of the system, but not by the liver or kidneys. It's cleared by an enzyme just floating around in the blood called plasma pseudocholinesterase.
Now, because of its pretty intense side effect profile, its use is heavily restricted. For adults, it is strictly limited to emergency intubations where the airway isn't controlled yet. And in pediatrics, the rules are even tighter. It's reserved exclusively for when a child has a full stomach and needs rapid sequence intubation, or as an absolute last resort rescue agent if life-threatening laryngospasm occurs.
Now, here is a crucial life or death point that you absolutely cannot skip: the severe hyperkalemia risk. See, when those muscles depolarize, potassium leaks out. Normally, this just bumps up serum potassium by about 0.5 milliequivalents per liter. No big deal. But in highly vulnerable patients, like those with extensive burns, massive crush trauma, or major neuronal injuries, that tiny leak turns into a massive flood. Potassium can skyrocket up to 12, triggering sudden, fatal cardiac arrest. Because of this, succinylcholine is completely, absolutely contraindicated in these patient populations.
On top of that, those initial muscle fasciculations forcefully squeeze the body's internal compartments. This dangerously drives up intracranial, intragastric, and intraocular pressures. Naturally, this means that it's contraindicated in penetrating eye injuries. You definitely do not want to squeeze an injured eye, but there's a clever workaround called pre-curization. If you give about 10% of a non-depolarizing blocker 3 to 5 minutes beforehand, you basically dampen those fasciculations and mitigate those dangerous pressure spikes.
And wow, the side effect cascade really doesn't stop there. Succinylcholine can trigger severe dysrhythmias, especially sinus bradycardia, so you need to have atropine ready to go. It also carries the dreaded risk of triggering malignant hyperthermia in susceptible folks. Oh, and if you give excessive doses, or if a patient happens to have abnormal pseudocholinesterase, which surprisingly affects about 1 in every 2,500 people due to a genetic mutation, you can induce a phase 2 block. This bizarrely acts just like a prolonged non-depolarizing block, leaving your patient paralyzed way longer than you'd expect.
When it comes to dosing, there's a really stark contrast between age groups. Adults get 0.6 to 1.1 milligrams per kilogram, and you generally want to err on the higher side just to make sure the block sets in. But pediatrics? They require much higher weight-based doses. We're talking 1.1 for children and nearly double that for infants at 2 milligrams per kilogram. But even knowing these doses, remember that routine pediatric use is usually avoided. The risk of sudden cardiac arrest in healthy-looking kids who actually have undiagnosed myopathies is just too terrifying.
Section 3. Short-acting agent, rocuronium, the rapid non-depolarizer.
So rocuronium offers this brilliant compromise. If you push a really large dose, like 0.6 to 1 milligram per kilo, it can actually approach the ultra-rapid onset speed of succinylcholine. But there's a catch, a massive trade-off. Using those high intubating doses prolongs the paralysis for up to 2 full hours. Still, it's a super versatile agent. It has some mild vagolytic action in kids, and you can even run it as a continuous infusion at 10 to 12 micrograms per kilo per minute.
Let's move to Section 4, Intermediate Agents, vecuronium and cisatracurium, sustained control.
Let's look at vecuronium. It's a highly potent, non-depolarizing, competitive blocker. Now, while it takes a bit longer to set in, around 2.5 to 3 minutes, what's genuinely impressive about it is its incredible stability for the cardiovascular system. It has virtually zero vagal effects, doesn't release histamine, and remarkably, it doesn't alter intracranial or cerebral perfusion pressures at all. It's just an exceptionally clean drug for maintaining stable hemodynamics.
However, there's a big catch here. Vecuronium is heavily reliant on the liver for metabolism, and it produces active metabolites. So you have to use extreme caution in patients with renal failure. If you run it for more than a couple of days in these folks, those active metabolites build up, and the paralysis can staggeringly take anywhere from 6 hours to a full 7 days to wear off. On the practical side, it comes supplied as a freeze-dried cake that you have to reconstitute and use within 24 hours. The standard adult dose is 0.1 milligrams per kilogram, but watch out with infants. They are highly sensitive to it and take about 1.5 times longer to recover.
Next up is cisatracurium, which is an isomer of atracurium. This agent is absolutely fascinating because it brilliantly bypasses the liver and kidneys entirely. Seriously, it breaks down right in the plasma through this beautifully elegant temperature and pH-dependent process called Hofmann degradation, leaving behind a metabolite called laudanosine. Plus, unlike its parent compound, it thankfully doesn't trigger any histamine release at recommended doses. All of this makes it an exceptionally safe and clever choice for patients with severe organ dysfunction.
And finally, Section 5, reversing the muscle blockade, bringing the patient back.
Okay, before you even think about drawing up a reversal drug, there's an absolute non-negotiable rule. You must wait for at least one spontaneous twitch on a peripheral nerve stimulator's train of 4. Why? Because even with that one twitch out of 4, a massive 90% of the muscle receptors are still blocked. If you try to reverse them while they're profoundly blocked with 0 twitches, the reversal will fail, or worse, it'll wear off early and the patient will catastrophically reparalyze. You definitely don't want that.
So, once you finally have that spontaneous twitch, the classic protocol uses neostigmine, an acetylcholine esterase inhibitor, giving 2.5 to 5 milligrams IV. But here's the thing. Neostigmine inherently slows the heart down to dangerous levels. Because of that, you absolutely must concurrently administer an antimuscarinic agent. That means either atropine or glycopyrrolate, dosed exactly to match the neostigmine, just to prevent profound, life-threatening bradycardia.
But in recent years, a truly revolutionary modern alternative has completely transformed this entire process. Enter sugammadex. It is the world's first selective relaxant binding agent. Basically, it's an incredibly sophisticated molecule specifically engineered to target our immunosteroid paralytics, namely rocuronium and vecuronium.
Sugammadex completely changes the game by literally encapsulating the paralytic molecule right at the neuromuscular junction, physically ripping it away from the receptor. It's almost like a molecular Pac-Man. And because it doesn't mess with acetylcholinesterase at all, it entirely avoids those dangerous cholinergic side effects. That means you don't need to co-administer those heart rate protecting antimuscarinic drugs we just talked about. You simply give 2 milligrams per kilogram for a moderate block or 4 milligrams for a deep block, and the patient recovers with unprecedented speed and smoothness.
So, based on this comprehensive point-by-point explainer, I want to leave you with a real-world application. Imagine you're in a high-stakes trauma bay with a severely injured crushed trauma patient requiring immediate intubation. Knowing that succinylcholine is absolutely contraindicated due to the risk of lethal hyperkalemia, which non-depolarizing agent and which rapid reversal strategy would you confidently trust to secure that airway safely? Think about the elegant pharmacology we just unpacked and how these specific molecular tools dictate life and death.